Pseudoarthosis of tibia is a thread to orthopedics surgeon. At the end of the discussion, you can understand what I uttered this language thread. The pseudoarthrosis of tibia actually present as a bow leg. Bow leg means angular deformity in the leg, and most commonly it is caused as a congenital pseudoarthrosis. But this congenital pseudoarthrosis actually a misnomer, and the clinical feature of pseudoarthrosis of tibia is associated with anterolateral bowing of the tibia, and bowing usually occurs at the junction of middle and distal one third, and deformity may be associated with skin dimple, limb shortening, dysplasia of fibula or ankle valgus, and usually it is unilateral, and there is a chance of uh, involvement of uh, cafe alert spot like this. And you must take a history of his family, that his father or mother is suffering from neurofibromatosis or not, because after proper examination you have to expose that boy or girl. You have to see the whole body, and you have to take a note of that, and after that you have to go for a plain radiological investigation or skeletal survey for that limb, for whole length, knee and ankle. Pseudoarthrosis tibia are not only a a pathology for tibia, it may be found in clavicle also. And treatment is only counseling, because no operative treatment is needed for this pseudoarthrosis of the clavicle, as the clavicle is the first bone to develop in our mother, first bone to ossify or appearance of ossification center in 45 days of our intrauterine life. There is the two ossification center for the clavicle, one for distal, one for proximal end, and for this end may not unite, so it can goes into congenital pseudoarthrosis of tibia. It is characterized by only swelling and painless swelling. There will be no pain. So after diagnosis, just counseling is enough. But you have to know the pathology, where the pathology lies. Otherwise, you cannot treat that patient accordingly. The pathology is lies in the periosteum. It is a hamartomas transformation of the periosteum with a fibrous unhealthy tissue, which never goes into ossification and never never form a good cancellous or cortical bone. Dor Paley is a orthopedic surgeon who first discovered this theory, and he is working on that. But before that, Odivilla is also think about this hamartomas transformation of the periosteum, and why it is most commonly found in the lower one third of the tibia. There is a theory, because the lower one third of the tibia actually very thin and subcutaneous, and maximum muscle bulk is going to tendinous structure over this lower one third, where the blood supply around this periosteum is very critical, and the stress of any limb is mostly over due to anatomical diversity. The stress of the bone is maximum over this area, so chance of fracture, as this is the weak part, is more high. So the chance of displacement and shearing force is maximum, so chance of non-union here is very high. Now Boyd has classified this non-union in 5 to 6 stages. Among them, some is asked for the MCQ. Type 1 is just a and present with anterolateral bowing, and this defect present since birth, and it is a congenital deformity, and the um, mostly this is not present with fracture. And type 2 is very important because uh, it is also called as a high risk tibia. It is most commonly most common form of congenital pseudoarthrosis of tibia, and it can cause a pathological fracture from a trivial trauma, and it can cause a anterolateral bowing allowing the hourglass appearance or hourglass constricture of the tibia, and it is surrounding by a sclerotic and obliteration of the medullary cavity, and this type is most commonly associated with neurofibroma type 1, and it has the poorest prognosis. So, so this slide is the most important slide for any type of MCQs. And third is associated with congenital cyst. Type 3 is associated with cyst, and type 4 there will be associated with a sclerotic part of the bone and chaotic segment there, but there will be no narrowing, and prognosis is good. And type 5 is associated with the dysplastic fibula. See, the fibula is also get scoliosis of the tibia. And type 6 specially, it is associated with intraosseous schwannoma. It is one type of nerve tumor, and it is extremely rare, may or may not be associated with CTB or any foot deformity, and the prognosis is also very bad. So just to remember all this, type 1 is just bowing, type 2 is the most common hourglass contracture, high risk tibia, spontaneous fracture is the poorest prognosis. Type 3 or type C is associated cyst, C for cyst. 4 is for sclerotic segment and stress fracture may occur. 5 for F, fibula. 5 for F for F, 5 for fibula, dysplastic fibula. Or 6 associated with schwannoma. 6, S for S, schwannoma. Schwannoma with S, 6. Okay. So, but you just you no need to mark up this name. If you can remember, that is better. But what you have to remember what are the other possibility, like bow leg may be present in case of osteofibrous dysplasia. This is also present with the bow leg. There is a benign disformation of the bone with a cystic and fibrous tissue. This is called osteofibrous dysplasia. In adult, this called as a amnioblastoma or adamantianoma. But in case of the pediatric age group, this tumor is called osteofibrous dysplasia. It is present only with bow leg. No need to do any operative intervention. Only radiological follow-up and counseling is enough for this type of tumor and bow leg. And another is very difficult to treat. This is called tibial hemimelia. Tibial hemimelia means there is no development of the tibia. There is only fibula, and most commonly this is bilateral. And but sometimes you can get this type of kyphoscoliotic tibia or S-shaped tibia and associated with calcaneo-valgus deformity of the foot. This is called kyphoscoliotic tibia or calcaneo-valgus deformity of the foot. It is still a very benign problem. It can be managed with the only massage can get rid of this problem, and after development of that child, that leg will be normal as any normal body. So the diagnosis and counseling is very important. And in how you differentiate it from the pseudoarthrosis, there will be posterolateral bowing, there will be no anterolateral bowing. Generally all the pseudoarthrosis tibia, generally there will be anterolateral bowing, but if there is posterolateral bowing, that is most acceptable and most benign, and generally this is unilateral. But you have to know this you have to exclude this this from the congenital pseudoarthrosis. How you exclude? By clinico-radiological association. And this is the most common type we have to encounter. Now, the most difficult portion is treatment. The principle of the treatment is dissection of that pathological bone, and the correction of the length, and the achievement of the fusion or union. And before going in details for the tumor, I just again repeat, pathology is in the periosteum. So whatever treatment or whatever operation you have described in the literature, all are very meticulously done, but I will show the result. First is excision of this pseudoarthrosis, and after that deformity correction and rigid fixation by bone grafting. Now we can use this type of rod. This is called Williams rod. It is intermedullary rod, and as they our old treatment, we used to done in the non-union, we used to do multiple operation. There is one operation is called Sikh kebab osteotomy, like preliminary osteotomy, but known, and there is a graft is called dual only graft. One graft from here and another graft from here. This is called void dual only graft. But all this treatment is not going to work, and after that they come with the vascularized fibular graft, where we have to take a vascularized fibula, and we have to put it in this pathological segment after debindment. But just take a note, the vascularized fibular grafting is taking very long time, and for child who is the age of 5 to 6 years, is it very easy to do this vascularized fibular graft? No, it is very difficult. But the all deformity, all type of problem can be solved by Iliarov. But there is a problem regarding the Iliarov in case of pseudoarthrosis tibia. The age of the that patient is generally 3 to 5 years when they present. Now, for doing a good Iliarov, or doing a distraction osteogenesis, the bone integrity at least need a good bone integrity. So before 5 to 6 years, they are that doing Iliarov is very difficult, because this type of traction cannot tolerated by this pediatric bone, but it is a option. Now there are more than 20 types of operation has been described in the literature. After the multiple operation, all the operation going to fail, and when all the resources will go to fail, then we can go for amputation. And the indication of amputation in case of pseudoarthrosis of the tibia is operation more than 2 to 3 times has been done, and or there is a shortening, significant shortening to 2 3 centimeter, more than 5 to 5 to 7 7 inches shortening is there, or there is the stiffness, decreased function or failed limb, or maybe associated with deformity of the foot, we can go for void amputation. But just think about the child and the family. patient is suffering from a disease and you are offering uh, amputation after so long a treatment. So is this is your child, can you accept this? So it is a frustration to our orthopedic surgeon, and that the treatment of pseudoarthritis is very difficult. Now this is just like this pandemic, and this is a threat to orthopedic surgeon. Pseudoarthritis of tibia have to explore in depth. So this is the latest treatment for pseudoarthrosis tibia described by Dor Palais. This is called X-Union protocol. Who, what we have done? He just think about the pathology. Pathology was defunct periosteum. So he transferred the periosteum from his healthy part to the dead part. He have taken iliac crest bone grafting along with the periosteum. He had put it over this factor side and with a good bone graft and internal fixation. So he had published his data to our internet, and but still he believed that to put this type of implant or plate, this is very difficult to tolerate a child, because that implant needs to implantable again, that can cause limb and discrepancy again. But somehow this protocol, he can achieve union of this pseudoarthrosis bone, but the limb discrepancy and the chronic long treatment is the drawback of that treatment. And last but not the least, in I just want to update you a small thing about this accordion principle. Just know the things. Accordion principle. Accordion is an instrument for singing or any program. There is a principle. It's called compression and distraction. When all hope to the union is gone, then only pressure cannot do that distraction. Sorry, only pressure can cause the the union of that unhealthy bone. What we can do, we can give a compression, then we can give a distraction. So repeated compression and distraction of this phacocyte can induce the localized gene for osteoblastic activity, and which can cause union. And one small study is going on medical college in Kolkata. We are just try to copy the Dor Palais X union protocol, like the periosteal graft, but we do not put this type of implant. We just put one KOR, and our added is a JES. This is called Josie's external stabilizing system. This is one type of instrument which can put into the bone to sparing this physis under siam, and we can put compression by turning this rod, and we can do distraction by deturning this rod. So clockwise is distraction, anti-clockwise is compression, and we can do it in a day we have to go for compression, and same day at the night we can go for distraction. And we have successful one cases, and but this case has been done outside with the failure of implant. But we need to do many work about that to say that we can do something for this hydrosis of the tibia. And